I'm Kenneth Tobin. I'm a child and adolescent psychiatrist at the intramural program in the National Institute of Mental Health. And I work with a vibrant and lively research group that has been studying this problem of irritability in children. And this afternoon I want to talk with you about what that research has been teaching us. In the intramural program, it's possible for families to bring children with problems like irritability or depression, and they can be evaluated and studied, and in some cases treated under our research protocols. So the outline for this afternoon, I'd like to say a little bit about clinical research and what that is, and then to begin in a historical way, talking about how we got into this business of studying irritability. Then I'll begin to talk a little bit about something called pediatric bipolar disorder and a controversy that surrounds it, and then move to talk about this problem of chronic irritability, which we here have called severe mood dysregulation, and say more about what the diagnostic and treatment implications from this work have been. And I'll end by talking about some assessment tips and guidelines. So clinical research, the important thing to know is that clinical research involves studies of people. There are some important kinds of studies that can be done with cells or animals, but clinical research involves people, and indeed, these studies allow us to learn ways to treat, prevent, diagnose, and to understand human disease. If one is going to understand human disease, one needs to have patients with those problems to understand how the disease starts, is kept going, and can be treated. So the process of doing clinical research involves, at the top here, beginning with an idea or a question about something about that disorder or disease. And based on that question, investigators write something called a protocol, and that protocol offers a detailed history of that idea or disorder and gives the background to why the idea or question is important. It also spells out who exactly is going to be studied to approach an answer to that question, and it has a detailed procedure for how that study will unfold, including what data will be gathered, how the data will be analyzed, and what will happen in the course of being in the study. That protocol is then reviewed at the bottom here by a committee of other scientific investigators who are not associated with the research group. It's an independent group, and they weigh the merit of that protocol and decide whether the question or idea is an important one that's likely to be beneficial for people. Once that has been approved, then the protocol is moved to a separate committee of individuals, once again, who are not part of the research group, and they assure that the procedures are safe and that participants will be appropriately treated in the course of the study. Once that has been approved, then it's possible for the study to move on, and we can gather and analyze data, and invariably it leads to other questions or ideas, and around we go with this. So if one were interested in enrolling in clinical research, the pathway looks something like this for our studies, and that is parents can call in or email us, and then we will respond with a telephone interview to learn a little bit about what are the problems that their child has been having. Based on that telephone interview, we will review information and decide that there may be some features that are not part of what we are studying, maybe help people get to resources in their community to get more help. Or we may decide that this is likely to be close to what we're studying and invite people in for a face-to-face interview. Before we have that interview, we'll proceed in a detailed way with a description of what will happen, and that's called informed consent. Based on that face-to-face interview, then we may decide that the person indeed has exactly the kind of problem that we're trying to study and understand, and we may move to enroll people in our study protocol, or there may be some features that suggest that they are not eligible for our research studies, in which case we will, again, kind of advise them on resources that they might turn to get help or assistance. So with that as a background, I'd like to talk a little bit about how we got into this business of studying irritability in children and youth. And this graph, just to orient you, is an important one from work that was done in 2007. If you look along the left side of the graph, you'll see that this is the percent of outpatient visits that are attributed to the diagnosis of bipolar disorder from a very large database of insurance claims and health maintenance organization claims. So this is many hundreds of thousands of insurance claims. And along the bottom, you see the years beginning in 1994 through 2003, so roughly a 10-year period. And in blue here, what you can see is that over this 10-year period, there was about a 60% increase in the rate of outpatient visits for adults, individuals 19 and older, that were attributed to the diagnosis of bipolar disorder. And that's an increase, to be sure, but not one that would be out of all proportion. But if you look at the graph in red, what you see is for individuals 18 and younger, there is a 4,000% increase. That is a 40-fold increase in the rate of outpatient visits being attributed to the diagnosis of bipolar. And within a 10-year period, this is a very dramatic, shockingly dramatic rise. It wasn't just in outpatient work, but also in inpatient studies that during roughly the same period, there was a 400% increase in the rate of bipolar disorder being attributed to children from inpatient discharge summaries. And in adolescents, individuals 13 to 18, a 300% increase in discharge diagnoses being attributed to bipolar disorder. Again, these are very dramatic rises in very short periods of time, and it left many of us kind of scratching our heads wondering what might be behind this. And this gets us to thinking about or trying to understand this phenomenon of bipolar disorder and the controversy that surrounds it. So to receive the diagnosis of bipolar disorder, one needs to have a manic episode, and in the most recent version of the Diagnostic and Statistical Manual, the kind of guidebook, if you will, for making diagnoses of psychiatric conditions, a manic episode is very clearly defined, and it looks like this. To begin with, there are these A criteria, and the A criteria speak to a distinct period of a change in mood, and mood is different during this period by being elevated, expansive, or irritable, and that it's accompanied by a change in behavior as well, and the change in behavior has to do with an increase in energy or an increase in goal-directed activity, being highly focused on something, and that this change lasts at least for a week, and the qualities of this change in mood and change in behavior are present most of the day, nearly every day, for at least a week. It could go on for longer, but it's most of the day, nearly every day. Accompanying these A criteria, so once you have these changes in mood and behavior, then the B criteria also are considered, and one has 3 of these symptoms if one has elevated or expansive mood. 4 if one is irritable. And these are, as you see here, present to a significant degree, so they're really noticeably different for that individual and a change from that person's usual behavior. The kinds of things that these B criteria speak to are having too good an idea of yourself, or maybe grandiose ideas, a decrease in your sleep, pressured speech, racing thoughts, problems with being more distractible, and engagement in activities with the potential that might be harmful and aren't really heeded appropriately by the person. And so what you look for is the combination of these B criteria in the context of a change in mood and behavior. So what this looks like is really that one is comparing how that person looks during a manic episode to the way that they look generally day to day when they're not in that episode. So usual behavior compared to behavior during the episode. And just as an example, someone that was in one of our studies was an unmedicated teenage boy, a high school sophomore, who's typically a bit shy, quite rule-abiding, but has this event for a week where he has a decrease in his sleep. He's only sleeping 4 to 5 hours per night instead of his usual 7 or 8. He has changes in his thinking where he believes that he's writing 3 novels at once. In fact, he has 3 notebooks that he's making comments in all at the same time. He sneaks out of his home and goes out into his neighborhood on what he describes as missions. During the night, he's looking for what he says are bad guys or people that might be intruders in his neighborhood, and that's actually contributing to some of his decreased sleep. And he also describes having auditory hallucinations during this time, where he hears this strange phenomenon of rumors of the past, things that are not very flattering about him. So these are very different features during this week than the way this boy typically functions. So what we wondered about with this very dramatic rise that I was just describing is really how it might have come about. And one of the things that we wondered about was how in the 1980s and into the 2000s, practitioners were invited to modify the DSM criteria of that time, DSM-4, and how they were applied to children. And thought leaders at that time said that one really couldn't identify episodes in children, or maybe it wasn't even necessary to make the diagnosis of bipolar disorder, and that one should use the label of bipolar disorder for conditions that displayed chronic, that is, not in episodes, symptoms of irritability. What they essentially said was that for irritable children, clinicians could double count symptoms and ignore the feature of an episode when making this diagnosis. And we now know that this is not correct. DSM-5 did a lot to tighten this up. But in many communities, many clinicians have been slow to make this change, and so it's still very common for children with chronic irritability to receive the diagnosis of bipolar disorder. So what happened with this modification? What happens when you double count symptoms and you ignore episodes as the feature? And I might invite you to consider this phenomenon of attention deficit hyperactivity disorder if you double count symptoms and ignore episodes. So what is ADHD? Well, once again, turning to the DSM-5, what you can see is there are 2 major domains, one of which is inattention, and it's defined by features like these. The inattention to details, trouble keeping attention on tasks or play, not listening when spoken to, not following through with instructions, avoiding things that require mental effort, being kind of disorganized and losing things, being distractible, being forgetful. And in red, what you see are symptoms that overlap very closely with those B criteria for a manic episode that I showed you a little earlier. So you can see how there's already a high degree of overlap between these two diagnoses. And the second domain has to do with hyperactivity and impulsivity. And in the DSM, these are defined as being squirmy or fidgety or moving about quite a bit or talking excessively or having trouble playing quietly. And impulsivity is interrupting or intruding, blurting out answers, or having problems waiting one's turn. And again, in red are features that map very closely to those B criteria for bipolar disorder, or a bipolar episode, that I showed you earlier. And so, just as a kind of an example, if you remove the episode criterion and double count symptoms, if you take the example of a child who has ADHD, you might see that they have trouble organizing themselves, they might lose things, that they're distracted, that they're forgetful, and you might say, oh, well, maybe we should also count that as a symptom of bipolar disorder, a symptom of distractibility. And being lulled into thinking that these are the same thing if you ignore episodes. So how would this unfold? Well, what you see here are these B symptoms with the features in red that overlap with attention deficit hyperactivity disorder. First, if we remove any requirement for an episode, most of these items in red are already going to be present. The second is if you compare children with these symptoms not to themselves, but to ordinary children, then they appear to have, indeed, these kinds of symptoms. And the only thing I need to do to translate this irritable ADHD child into someone with bipolar disorder is to say that they're irritable. And voila, irritable children with attention deficit hyperactivity disorder could be relabeled as having bipolar disorder or a manic episode if you ignore the episode criterion and allow yourself to double count symptoms. So based on this idea, we began to think about a phenomenon of mood dysregulation and chronic irritability in children. And the question that Dr. Ellen Liebenluft bravely raised at this point was, is severe irritability really the same as bipolar disorder? And in order to answer such a question, the first step would be to create a definition so that one could identify these children in a reliable way and that others could do so as well. And then to answer the specific question, one would gather data and use that data to compare children with this phenomenon of chronic irritability to those with classic episodes of mania or hypomania that would be bipolar disorder. And the kinds of data that one would gather would be what we call longitudinal data, so what happens to people over time. A second would be looking at their family histories, because the kinds of psychiatric disorders that run in their families ought to be similar. And then, of course, also to look at brain function and brain activity, because if these are the same, then there should be a considerable degree of overlap. So, based on those conversations and conversations with other investigators, indeed, Dr. Liebenluft and her lab group came up with a definition for this problem of chronic irritability, which was called severe mood dysregulation. And it began with the idea that there was anger, sadness, or irritability that was present most of the day, most days, and was evident in more than one setting, really evident to those that are around the child. It was also specified that there would be hyperarousal symptoms, and those listed here are ones that map very closely to those symptoms in ADHD and in the B criteria for a manic episode that I showed you earlier in red. And in addition, that there would be these episodes, these events of outbursts that would be excessive reactivity, and that they would have these outbursts at least 3 times per week. And for many of the children that we saw and heard about, they were happening daily or many times a day, but that they would happen at least several times a week, not just once in a while. We specified that they needed to be present for at least 12 months, so it wasn't something that just came up around a particular situation or event, but really was highly characteristic of that child's functioning. And we said that they had to have the onset of this before they turned 12, so that we wouldn't be just looking at adolescents that were in that particular developmental phase where they might be more oppositional or pushing back against parents' rules, but had been fine up to that point. And we also did not want to be studying children younger than 7, because some of the things that we were asking people to do might be difficult for much younger children. And we also recognized that toddlers and preschoolers and immature children can have problems with irritability when they're 5 and 6, but that wasn't being seen in the same way as this phenomenon of a manic episode. And so the clinical picture of children that would have this kind of problem is displayed here. This is a combination of a few different children who came into our study, but a 10-year-old boy is angry, as described by his mother, all the time, that he argues, she says, constantly. There's been a lot of aggression in their house. That is, he's broken holes in the drywall, doors have been broken off their hinges, household items have been damaged during the course of some of his outbursts. In fact, the police had been called to the house 3 times in the last year because the parents were told that they shouldn't be trying to restrain their son, that might lead people to question about his safety there, and so the police should be brought in to help contain him. He regularly was hitting his parents. With friends, he had really few friends. He was bossy, demanding with them. He would often have fights with his peers at school, so it wasn't just a problem at home that was displayed. When he came in, he was on high doses of stimulant medication. He was on 2 different atypical antipsychotic drugs, medicines that are often used to calm individuals with agitation, drugs that you might know as Risperdal or Seroquel or Abilify. And he was also on another drug that is often used for ADHD. And he also was getting medication to help him sleep. So he was on, 4 or 5 different medicines all at one time here. His first mental health contact was at age 3. He had a 3-week hospital stay when he was 9. He had been on 9 different medicines in the past, and his diagnoses in the community were bipolar disorder, attention deficit hyperactivity disorder, anxiety disorder, and mood disorder. So I think we could all agree that this is a very severely impaired boy, someone who's very ill. So looking at children like this, we really wanted to know, well, what does the data tell us about what happens over time? What's the longitudinal course? And to look at that, we were able to draw on something called the Great Smoky Mountain Epidemiological Study, which was a study of about 1,400 children who were gathered together because they were all participants in a health maintenance organization. And these 1,400 children were assessed at age 9, 11, 13, 18, and 27 years of age with a very high degree of retaining them, a very expensive and ambitious study. what was important about this is that when the data was gathered on these children, it wasn't just gathered by what diagnoses they had at the time, but it was also gathered by what symptoms were present. And that allowed us to go back and ask the question, well, how many of these children would have had this feature of severe mood dysregulation as we defined it? And to begin to ask questions about what became of children who met those criteria and what sort of diagnoses did they have at the time. So the most common diagnoses at the time that they came into the Great Smoky Mountains study, as you might expect, were anxiety disorders and something called the disruptive disorders, that is, oppositional defiant disorder, attention deficit hyperactivity disorder, and conduct disorder. And that isn't such a surprise given the kinds of features that I've been describing. But the other thing that was important and striking was that about a third of the children with this SMD feature had no official DSM diagnosis. Remember that this definition of severe mood dysregulation wasn't in the DSM at that time. And so a full third of them didn't meet any diagnosis because they would either be missing a symptom or they wouldn't have had their symptoms for long enough. And so there was no place in the diagnostic system for this problem of chronic irritability that they displayed. And the other thing is it wasn't every child by any means, but it was about 3.2% of the children in that epidemiological group who met the criteria for severe mood dysregulation that we spelled out. The outcome data, of course, was very interesting to us, and what it showed was that depression and anxiety were the things that seemed to emerge from this picture of severe mood dysregulation. At age 18, the only condition that was predicted if one had severe mood dysregulation at 9 or 11, the only condition that was predicted was major depression at 18. And in fact, this kind of made together group of symptoms called severe mood dysregulation was a better predictor of having major depression at age 18 than even if one had major depression at age 9 or 11. So that made it actually a very robust predictor indeed. And in this entire cohort, there was not one case of a manic episode or bipolar disorder that emerged. And so that cast some doubt on this feature of chronic irritability just being a forerunner of later bipolar disorder. And when the group at Duke that has worked so diligently in this area went back and looked at the individuals at age 27, looking at this diagnosis that we'll talk about in a moment called disruptive mood dysregulation disorder, or DMDD, what they found is that individuals with that constellation of features at 9 and 11, it was highly predictive for them having depression and anxiety disorders at age 27. It also predicted having other diagnoses at the same time, so there were many other conditions that they had, and it also predicted a poor outcome for them in their psychosocial adjustment, in their occupations, in their ability to complete their academic course of study. It was really a problem for them going forward and spelled a poor prognosis. We also had individuals that we were gathering here and studying, and our colleague, Dr. Aguirre-Stringaris, looked at this data and published it in 2010. And what we looked at was, well, if this feature of chronic irritability is supposed to be a forerunner of a hypomanic or a manic episode, what happens to the children that have come into our studies? And so we followed them over a period of roughly 2 years, and what we learned is that among those that had episodes of mania or a manic episode or a hypomanic episode, the rate of having a subsequent episode was about 63%, or almost 2/3 of them in this went on to have a subsequent episode. If you looked at those that had severe mood dysregulation, the rate of having a hypomanic or manic episode over this 2-year period was about 3%. So a very dramatic difference. And in fact, those with severe mood dysregulation really didn't go on to develop bipolar disorder very often at all. So it wasn't a good predictor of later bipolar disorder. And in fact, severe mood dysregulation can't really be seen as the early appearance of bipolar disorder. So a couple of things to say about this, because we think about these problems with dysregulated behavior, irritability, as being a behavioral problem, and often refer to it as externalizing because it causes problems for those around the child, or they're often referred to as behavioral or disruptive disorders, so things like oppositional defiant disorder. But the thing that we have been looking at and thinking about is how much emotion or mood is a component, and to draw your attention to the fact that these are not purely about behavior. In fact, that mood problems are very common with these conditions of externalizing disorders, and that what starts off as this externalizing problem really becomes a risk for what is later on an anxiety or a depressive or an internalizing problem. And that perhaps treating the mood component here could be critical to helping these individuals recover and could be important for their overall eventual outcome. So just to kind of summarize here, this group of symptoms that we drew together and called severe mood dysregulation is pretty common, about 3.2% in the child population, but by no means is it every child who has this. Also to underscore that what looks like an externalizing problem now is really a risk for an internalizing problem like depression later on, and that this construct of chronic irritability that we generated was a robust predictor of depression in early adulthood. What did we learn from our family history studies? And our colleague Melissa Brotman published this in 2007. And there we were able to interview parents of children with this classic bipolar construct of episodes of mania or hypomania, and then to compare the diagnoses among those parents to the diagnoses among the parents of those with our construct of severe mood dysregulation. When we did this, we were able to rely on interviewers who used a rigorous research method to obtain these diagnoses, and they were also blind as to the child's diagnosis. They didn't know whether these were bipolar children or children who had severe mood dysregulation. And what emerged from that study is that the rate of bipolar disorder in the parents of children with classic bipolar disorder was about 33%, so a third of the parents. And in some cases, the parents were unaware that they had bipolar disorder, and this was the first that this was being brought to their attention. And to compare that, the rate of bipolar disorder in the parents of children with chronic irritability, what we called severe mood dysregulation, was about 3%. Once again, about the rate of bipolar disorder in the general population. So bipolar disorder was the only diagnosis that was different among the parents in the two parent groups. So rates of anxiety, rates of depression, rates of problems with getting along with other people, problems with anxiety. These were all about the same in both parent groups. The only diagnosis that was different in these two groups was bipolar disorder. So the rate of bipolar disorder in the parents of those with severe mood dysregulation was about the same in the general population, as I just said. So we also are very involved, very interested in brain function and how the brain works, and we think that understanding how the brain works and linking that to problems in behavior and disorders is an important way to help people and understand illness. And so we do things like magnetic resonance imaging, which is shown in this delightful cartoon that was created by one of our patients who has given me permission to use it for just these kinds of circumstances. You can see her there in the scanner and the investigators and helpers out in the outer room there as she's inside our scanning machine. And from this work, we've been able to learn a great deal about brain circuitry and actually how brain circuits relate to one another. And it's now becoming clearer that irritability may be closely related to the interplay among circuits in the brain. And the circuits that are important have to do with kind of moving from the bottom of this figure to the top, thinking first about these in red, which are systems that orient one to emotional information and the perception of emotion information. So how your brain actually processes emotion information. And that in the tan color here are a set of regions and circuits that have to do with the interface between how we think and these emotion stimuli, the processing of these emotion stimuli, and also how we draw our attention to these emotion stimuli. And then at the top here in blue are the features that we tend to think about most with thinking, how we regard information, how we control our bodies and plan to use our bodies when we have to carry out tasks, and how we pay attention to different things that are going on around us. And so the interplay of these three systems appears to be quite important and may be precisely where the problem in irritability resides. As a result of this work, we have a host of findings, but two of the important ones that I just wanted to point out this afternoon are that there are really significant differences in brain activation among individuals with chronic irritability when they're performing tasks where they have to look at a face that displays an emotion and label that emotion or recognize the emotion that's on a face. That the work in the brain really looks different when carrying out this task compared to children with other disorders. And a second important difference is that tasks that have to do with paying attention to things around us or the way in which we appreciate the reward of doing something correctly or getting something right, during times of a heightened emotional state, like during frustration, that the way in which the brain is activated and these circuits relate to one another is different among our children with chronic irritability compared to those with other diagnoses. So looking at the way these circuits behave and how they relate to one another has been important in our work and has made us begin to think a little bit about how these might translate into treatment. So there are diagnostic and treatment implications that come from this kind of work. One is that we've become interested in irritability as a function, as a problem itself among children and adolescents. The work that's begun to look at this among adults has demonstrated that about 10% of the adult population has impairing irritability for at least a 6-month period of time at some point in the lifetime of adults. And this was ascertained in a very large study called the National Comorbidity Survey. They really looked at individuals across the country, not because they had conditions, but just because they happened to be randomly obtained for this study. And if you looked at the individuals who had irritability among these adults, they actually had pretty significant conditions. So irritability was, if you will, a piece of something much bigger and important, and it wasn't easily dismissed. 92% of these adults had mood disorders, anxiety disorders, impulse control disorders or problems with substance abuse that were really interfering with their lives. We also know that in children, about 40% of those who are entering treatment in clinics across the country have elevated symptoms of emotional lability related to this being easily angered or losing their temper. It's one of the most common symptoms that will bring a child to psychiatric attention. So despite the problem and the relatively high frequency of this problem in the population, it's surprising that there's no official definition for irritability, and it means that those of us doing research in it have had to develop tools and definitions ourselves. We also have come to recognize that irritability falls along a continuum, that being annoyed or irritable with things can be a part of ordinary life in otherwise healthy people, but it can also emerge in greater and greater degrees of severity until it really reaches pathological proportions that are impairing, and that we have to begin to recognize when one crosses the line into a pathological level of irritable functioning. We also know, as I alluded to earlier, that there are developmental considerations when it comes to irritability, that we all know about the terrible twos and how toddlers and very young children have more problems with containing their frustration and irritability, and we expect that of them. It doesn't mean that they have a pathological condition. At the same time, we also recognize that there are adolescents at the other end of the developmental spectrum of childhood who have a kind of a sarcastic, annoyed, kind of withering look to rules and conditions that are set on them, and that kind of goes with the territory for their developmental phase. And I guess the last thing to stress as we've come to understand and think about irritability is that there are many disorders that have a symptom of irritability, and I wouldn't want anyone coming away from this talk thinking that irritability means just one thing. In fact, there's a handful of different diagnoses where irritability is a very prominent feature in the DSM. So thinking about irritability, there are two components that one might be invited to think about if you're working with someone or living with someone who has irritability, to think about these two elements. And one is how irritability can be kind of always in the background, kind of a grumpy, annoyed, negative, having a hair trigger or being easily triggered to outbursts of anger. So that's one kind of feature. And then the other are these outbursts, the flashes of anger or explosiveness. They may be verbal, they may be physical, but they're quite in excess of whatever the prompt or stimulus was. They're quite out of proportion. They may be in response to fairly innocent or ordinary requests or fairly ordinary events, but they're way out of proportion. So the other thing that we've been looking at is what contributes to irritability, and we understand that actually there's a large genetic component. We think that one's genetic makeup may contribute about 30 or 40% of the risk to irritability in adolescence. And it would be useful to know that this is about the same genetic contribution that we see for anxiety or for major depression and depressive disorders. So it's not completely genetic, but it's also not that it's all about the environment. There's actually a substantial genetic risk that makes a contribution. It's also interesting that over time, this genetic piece may be more important for men than for women, and that it's clear that environmental factors make a much greater contribution to irritability for adolescents and adults. It may be the genetic piece is more prominent for children. Based on this work, ours, but actually many investigators across the country beginning to look at irritability, the committee that creates diagnoses for the Diagnostic and Statistical Manual generated a new condition in the DSM-5 called disruptive mood dysregulation disorder, or DMDD. And these are the criteria that the DSM-5 sets out for DMDD. And you'll see that it has some features that resemble what I talked about with severe mood dysregulation. You see in A here that there are recurrent outbursts that are out of proportion and aren't consistent with that child's developmental age, that the outbursts occur at least 3 times a week or more, that it's anger or irritability that's present most of the day, most days. You saw that language earlier, that it's present for at least 12 months, usually much longer, and that there isn't any period of 3 months where there are no symptoms present, that it's observed across settings, so it's not just something that happens at home. It isn't used for individuals under 6 or for those for the first time who are over 18, and the DSM excludes other conditions if they're happening at the same time. So if you have major depression or something like an autism spectrum disorder or post-traumatic stress disorder, one wouldn't give DMDD also. So the implications of this are that we've become very interested and involved in how one might treat this. And frankly, we have a lot to learn about how to treat irritability. But if this problem of chronic severe irritability was thought about as more like attention deficit disorder with anxiety or attention deficit hyperactivity disorder with depression, instead of bipolar disorder, one would begin to treat it in a different way. One would think about giving stimulants, drugs like methylphenidate, which some of you might know as Ritalin or methylene or Metadate, or drugs that use as their base dextroamphetamine, so things like Adderall or Vyvanse or other kinds of agents for treating ADHD, and we might combine those with treatment for anxiety or depression. So we might give medicines like serotonin reuptake inhibitors, drugs like Prozac or Zoloft or citalopram, or use non-pharmacological treatments like cognitive behavioral psychotherapy or combinations of these to treat DMDD. We actually had embarked on studies here, and we've learned a little bit about treating DMDD. We started off doing a study of lithium carbonate because that's a very useful drug for individuals with classic bipolar disorder. And what we learned from that study, which was done very rigorously, is that it was no more helpful to children with severe mood dysregulation than the placebo that we gave them. And so it would be not a drug that one would recommend for DMDD or severe mood dysregulation. But in doing that study, we also saw how powerful environmental interventions were to help these children. About a third of the children who came into our inpatient unit here at the NIH to be studied for this were doing so well on our inpatient unit that their irritability dropped beneath any sort of threshold that would allow us to treat them with lithium. And so we ended up doing other sorts of treatments to assist them, but they couldn't be enrolled in that part of the lithium study because the irritability was not present when they were on our inpatient unit. But based on that, we did see that a number of the children had significant anxiety and depression and very severe attention deficit hyperactivity disorder, and so we treated them openly with stimulant medicine and with serotonin reuptake inhibitors like fluoxetine, like citalopram, like sertraline. And in fact, that led us to the study that we're doing now, which is a rigorous scientific study of the combination of stimulants. And then once those stimulant drugs have been optimized for ADHD symptoms, children get either a placebo added in or a serotonin reuptake inhibitor added in. And we're looking at that to see how that may be useful to children with chronic irritability. But we also now, even more recently, have been looking at whether non-medication treatments, non-pharmacological interventions can play a role in treating children. And based on some of the findings that I showed you earlier about labeling faces and emotions, we've begun to look at how individuals with severe mood dysregulation or disruptive mood dysregulation disorder often mistake faces and see them as having a hostile intent or being angry when they're not. And so if you look at this slide, you can see how one could create, if you will, a morph of a person's face from, on the far left here, this happy, smiling person who clearly is happy, all the way to, at the far right, someone who is clearly angry, and many shades of gray in between. And you can begin to ask people, if they're shown faces, not all at once like this, but one at a time, is this person happy or angry? And force them to choose happy or angry, happy or angry. That there's a point at which they'll begin to see, oh, that one more happy, these in the middle here, oh, that one more angry. And you can begin to look at the balance point. We've begun to look at whether there might be computer programs that would teach children to shift the balance point so that when they see these faces in the middle that are more ambiguous, rather than thinking about them as being angry or hostile, they would begin to think about them as being more neutral or happy. So can we shift this balance point more to the right so that more of the faces would be seen as happy or neutral than angry or hostile? The other thing that we've been looking at vigorously is whether there's a role for something called cognitive behavioral therapy. And the principle of cognitive behavioral therapy is that thoughts and behavior and how one's body feels and one's emotions are all tightly linked together, and that we can begin to alter, help, treat how people function by intervening at any one of these four important points on the compass. And so beginning to help people think about how their bodies feel, how their emotions are going, what their behavior is doing, how their thoughts are going at the same time may be a way in to assist them and to begin to think about an approach to irritability that's like the approach that's used for anxiety, where individuals might voluntarily expose themselves to situations that are mildly annoying or irritable and begin to tolerate those and manage those successfully, and then move up the ladder, if you will, to circumstances that are more and more annoying or irritating, using skills to help themselves feel calm and tolerate those to a greater and greater degree. And so we're exploring whether a manualized approach to this work can be helpful to children with DMDD. So there are some tips or guidelines that follow from this. One is when children and parents come here, we interview them separately. We think it's important that each have their story to tell and that we get the best data by talking to parents and children. Sometimes it's useful to bring them together afterwards where they see things differently and they can help us with getting a better fix on what's going on. But this way of talking to them separately is quite important. The other is that we look at their behavior and functioning across different settings. So, of course, we are interested in what happens at home, but we also look closely at what's happening in school and what's happening with their peer relationships. And then the last part is that we really maintain a careful review of what that child is like in their developmental level, and to have a high degree of cultural sensitivity, because family and community cultures have a powerful influence on how we understand behaviors, feelings, and thoughts. So if one is thinking that somebody might have DMDD, the advice here is to look for a routine pattern of outburst behavior, and that those outbursts will occur at home and at school and or with peers, and to think about the mood, the anger and irritability that's going on in the background, not just during the outbursts. To think carefully about that child's developmental level, and to consider also how parents or those around the child kind of modify what's expected. They make accommodations for the child. So things may be, not as severe as one might think, but there's a lot of dancing around to keep the child happy. That suggests considerable impairment. And then to look at the overall impairment that the irritability produces. And also to think carefully about depression, because we're now moving into thinking more and more about depression, particularly in adolescence, and to raise the question about, are we looking at something that's major depression? So to look for symptoms of sadness as well as irritability, to look for loss of pleasure in things that used to be enjoyable, to look at problems with concentration and low self-esteem, if the child or adolescent is having thoughts about wishing they were dead or hurting themselves, and to look at changes in their bodies, their sleep, their energy, their appetite, compared to the way they usually function. So this final slide is a flyer. If people might be interested in learning more about the work we're doing, if they have questions about some of the things that I've talked about this afternoon, you're invited to write us or to call. You see in the oval a phone number that you can call into if you have an interest in our work, or you can write us at irritablekids@mail.nih.gov. Thank you very much.